So patients who require treatment with primary or secondary myelofibrosis currently are symptomatic patients, usually who have enlarged spleen. Sometimes they have cytopenias, and we have few JAK inhibitors which are currently approved for these patients, including the oldest and most commonly used one, JAK1, JAK2 inhibitor, ruxolitinib. So these patients benefit from JAK inhibitors by their symptom improvement, decrease in spleen size, and perhaps a little bit more improvement in overall survival, which was post-hoc analysis of ruxolitinib studies. So, but what we do not have is clear-cut evidence for disease modification, meaning prevention of progression of patients with myelofibrosis to acute leukemia, as well as improved overall survival. And ideally, we would like to have treatments which not only improve symptoms, decrease the spleen size, but also make patients' life longer and prevent them from developing acute myeloid leukemia, which is a serious complication, which is very difficult to manage. I perhaps should focus on the results which were presented at ASH 2023. This was the part of phase 1 part of this study, Export MF034, which looked at patients who were treated at 60 milligrams of selinexor in addition with ruxolitinib. So this study showed impressive response, specifically the response in the group which received the treatment, efficacy evaluable group. At week 24, the SVR35 response, or spleen volume reduction by 35%, was noticed in 92% of patients. Again, the study was small, and it had only 12 patients, so 11 out of 12 patients responded with SVR35. And TSS50 response, or total symptom score reduction by 50% at week 24 to efficacy evaluable group, was 78%, and this was evaluated in this was the response of 7 out of 9 patients. So there were also responses among patients who could not take a high dose of ruxolitinib. So ruxolitinib selection in the study is based on platelet count. When patients during the study, those who have platelet count between 100 and 200 receive 15 milligrams twice a day, and above 220 milligrams twice a day. And a lot of patients are not able to tolerate that because, for example, they develop significant cytopenias. And those reductions lead to use of smaller doses of ruxolitinib, and 5 milligrams twice a day dose is the lowest dose currently recommended. With this dose, we see infrequent responses from the standpoint of symptoms and spleen reduction. But among patients who received this low dose and who at the same time received selinexor at 60 milligrams once a week, we noticed that the improvement of symptoms and spleen size was still present. It is a small number of patients, but it is an interesting signal, perhaps highlighting the fact that selinexor and ruxolitinib can work together in these patients, helping them with symptoms and spleen volume reduction. So in addition, this study showed improved in cytokine profiles, as well as a decrease in variant allele frequency of driver mutations, as well as high-risk mutations in these patients. Again, it is a small study, but as the result, the 60 milligram dose was selected for the phase 3 trial, which is now finishing accrual and plans to enroll 350 patients. The SENTRY trial, also known as the Export MF034 study, is a phase 3 trial which enrolls patients who are JAK inhibitor-Naïve, so they have not been treated. So these are newly diagnosed patients, or patients who have myelofibrosis primary or secondary, post-PV, post-TT, who didn't receive JAK inhibitors like ruxolitinib. And the study enrolls patients who are symptomatic and with DIPSS 1, 2, or so DIPSS intermediate or high risk. And these patients usually need treatment because they have symptoms. But this study randomizes them to either ruxolitinib with placebo or ruxolitinib plus selinexor. It's a blinded study. And the dose of selinexor is 60 milligrams. It is given weekly with antiemetic premedication. And the results of the study are 24 weeks improvement in spleen volume response, and also the total symptom score, average total symptom score with baseline compared to week 24. There are a number of secondary endpoints as well as exploratory endpoints, including overall survival as a secondary endpoint, as well as improvement in anemia and some biomarkers. And biomarkers are important, as this may be a sign that selinexor, if it pans out, may be disease modifying. So that includes changes, variant allele fraction of driver mutations, as well as other high-risk molecular risk mutations, as well as cytokines, which play a significant role in this patient's symptoms and disease progression. We're certainly looking forward to the readout of the study, which I suspect will happen in 2026. And I'm hoping to see the improved outcomes in ruxolitinib plus selinexor arm, not only from the standpoint of spleen volume reduction and reduction of symptoms, but also some important secondary and exploratory endpoint, like overall survival, for example. Again, it will take a while to get to this particular endpoint, so we're looking at biomarker response, including cytokine profiles in those patients who have been treated with selinexor, as well as variant allele frequencies of driver mutation and high molecular risk mutations. I think we're in the era when we're actively exploring so-called doublets in the frontline treatment of patients with myelofibrosis who are high risk and who are symptomatic. And I hope that one of these doublets is going to be approved one day. And of course, in addition to good effect on symptoms and spleen volume, we're looking for evidence for disease modification to justify such an approval. And it is certainly something we need for patients with myelofibrosis whose life expectancy, especially high-risk patients, remains not very good. And on average, median survival for these patients is between 5 and 6 years. Certainly something we would like to improve.